have Paul Speigel, Michael Desjardins, and Patricia Oke-Oghene Obroh. Paul is a distinguished professor and the director of Center for Humanitarian Health at Johns Hopkins University. Michael is a special epidemiologist and medical geographer. He's also an assistant research professor at Johns Hopkins University. And finally, Patricia works with Action Against Hunger in Nigeria. I believe she's still a rapid response mechanism specialist. And so I'm very pleased to hear from you your experience on CADI implementation in Nigeria in a different context, different settings. So over to you.
Thank you so much. Thank you for joining us today. I don't know if you can hear me clearly.
Loud and clear.
Okay. As you said earlier, my name is Patricia Obroh, Action Against Hunger. I'm the WASH head of department based in Abuja, working with Action Against Hunger. And with me, as you said earlier, is Paul from Johns Hopkins Center for Humanitarian Health and Michael from Johns Hopkins Special Science for Public Health Center. So we're excited to share with you today our latest research that was recently published with PLOS Medicine. First, I'll provide to you a background of the broader MIST method, and Michael will discuss the methodology and results, and Paul will end with its implication for cholera outbreak response. Our colleague Solomon is online for question and answer session. Next slide, please. Yes, for this research, it was done in Borno, Adamawa, and Yobe State in Nigeria from September to December 2021. And that year, Nigeria experienced the largest cholera epidemic in 20 years. Much of these epidemics were concentrated in the northeast of Nigeria, which experienced insecurity fueled by conflict. And since 2013, over 3 million Nigerians have been displaced as a result of this conflict. And so this prolonged crisis both increased the population's vulnerability to cholera and also hindered the response effort. Next slide, please. This study was really in partnership with Johns Hopkins Center for Humanitarian Health, Action Against Hunger, and Solidarity International. It was a MIST method, and the study had quantitative and qualitative data, and the study was not influenced by either of the NGO's standard of operations. And today we are really focusing more on the quantitative part of the study. And this has two phases, which will be explained in a later slide. But both of these quantitative phases had very large sample sizes, which was about 46,000 samples of data from various households. Next slide, please. Now, in this the study overview, which was implemented by Solidarity International and ACF, we all had various standard of operations. And during the outbreak, ACF and Solidarity received line lists from the Center for the Cholera Treatment Centers. And this line list that we are getting from this center was used to carry out the CATI response in the case household and the neighboring household. And during that process, also cholera kits were distributed, such as soap, aqua tabs, IEC materials, and jerry cans. Also, we disinfected some key surfaces and also shared some hygiene promotion messages. Next slide, please. Next slide, please. Yes, so on the quantitative data that was collected in the first phase, as I said earlier, the research enumerators from the various, and also the rapid response team from the various organizations went with the CATI team and observed the CATI response. And also in the second phase, after 10 to 14 days, the enumerators returned back to these CATI rings and carried out some also response, and some data were collected, such as the GPS locations, tried to also see the existing WASH infrastructure. We also collected the demography of each household and checked the FCRO of each of the household and carried out the CAT interventions. Next slide, please. So now I'll hand over to Michael. Thank you.
Thank you, Patricia. So today we're going to focus on the methodology and findings from our latest manuscript, as Patricia mentioned, published in PLOS Medicine a couple weeks ago. We used data collected during phase 1 of the study. So I invite you to click on the link. We could share it in the chat as well to look at more of the substantial stuff and details of the methods. Next slide, please. So there's definitely a lot of challenges with these data and coming up with a method to evaluate CATIs in our study areas. So the complexity of real-life uncontrolled CATI data in an urban humanitarian setting required adaptation to a more innovative spatiotemporal methodological approach. In particular, you can see in these images, especially the one on the left here, the degree of overlap of CATI rings in more urban areas. So we decided, we know where and when CATIs were implemented for each household with cholera. In terms of the case households, our method examines if there were clusters of excess risk of cholera incidence within a given area and time period for each of the 3 states. Next slide, please. So we decided to run 3 different models to evaluate CATIs. Our first model is an unadjusted model where we're just looking at cases and population without looking at any interventions. For model 2, we call this the environmental model, where we have cholera cases and population for model 1, but now we adjust for distance to cholera treatment centers and different wash infrastructure variables like improved water source, improved latrine, and hand washing stations. And finally, for model 3, we call this our full model, where we bring in the variables for models 1 and 2, but now we look at the CATI variables as well as that we adjust for, including supply of aqua tabs and soap, hygiene promotion, bedding and latrine disinfection, ring coverage, and response timeliness. Next slide, please. So it was nice to see Ruan applying a space-time scan statistic to CATIs as well before. So I'm glad to see others are thinking about using this great technique to look at cholera and CATIs as well. So here we're using a prospective Poisson space-time scan statistic to detect potential cholera clusters and evaluate the impacts of CATIs based on the 3 models that I presented in the previous slide. So non-significant clustering and no clustering means that cholera incidence was occurring at non-outbreak levels, so no excess risk. And again, please see the paper for more details on this method. And the data that we use were aggregated to 150 square meter grid cells, which approximates the 150 meter radius of the CATI rings. And so we ran the model each day of the study period for each of the 3 states, Yobe, Adamawa, and Borno. And we look back the prior 28 days to look at potential spatial and temporal trends of the cholera transmission and, of course, the interventions as they were being delivered. The observed patterns were then compared to simulated data sets to determine if the clusters occurred by random chance. So next slide, please. And so we have some descriptive statistics here, of which these are just a few, highlight some of the challenges identified in our qualitative key informant interview paper in PLOS neglected tropical disease, and notably the challenges of reaching all cases in neighbor households in supply stockouts. So when supplies were limited, households with cholera cases still received the interventions compared to the neighboring households. So for example, in Borno, 96% of the case households received complete supplies, while only 44.3% of case neighbors received complete supplies. So they were still prioritizing the households with the initial cholera case. Another challenge teams found was a high population density in urban areas. This was especially true for Borno, which is urban, which you can see in row 4 of the table here, that only 4% of the households in the rings received an intervention. However, this still equated to approximately 25,000 households. So in Borno, while the population or proportion of households, that received a CATI was low, the number of CATIs was more than double that of Adamama, which is peri-urban, and then Yobe, which is a truly rural setting. Next slide, please. So now for our modeling results, CATIs were associated with a reduction in cholera clusters. And after the CATI interventions, cholera clusters had lower associated risk, were less frequent and smaller in size, occurred for shorter duration, were less likely to reoccur, and remain below epidemic levels. So the purple line on the figure on the right here represents the results of model 3, our full model, which accounts for our WASH and CATI variables. So the figure shows that the full model exhibited the largest reduction or attenuation in excess relative risk of cholera, with many days showing non-outbreak levels of incidence, and you could see this clearly by comparing it with the solid green line of just looking at cases and population. So in general, no significant clusters were detected for both adjusted models, which means no areas or time periods showed statistically higher concentrations or occurrences of cholera after accounting for both WASH and CATI. Next slide, please. So I am a spatial epidemiologist, so I have to show some maps of our results, and hopefully this will drive the point home that CATIs were really reducing relative risk of cholera across our study period and study areas. So here we have Borno. We showed the maps of daily relative risk estimates for the state on days 20, 45, and 90, but we do have results for each day since we ran the models for each day. The black outlines represent significant cholera clusters, while the darker colors represent higher relative risk, whereas yellow represents no observed cholera cases in that 150 square meter grid cell, and for that day. So for model 1 on the left here, in the first panel, we detected statistically significant clusters of excess cholera risk on days 20, 45, and 90, with many locations having a relative risk greater than 1, outside of the clusters as well. Next slide, please. So for the second panel here, this is model 2, which includes just the WASH variables and distance to cholera treatment centers. So we detected a very small cluster on day 20, while the overall relative risk, number of clusters, and size of the clusters were further reduced. Next slide, please. And finally, looking at days 20, 45, and 90 for the full model, which includes the CATI interventions, this demonstrates a vast reduction in relative risk across Borno with no excess clusters detected. And furthermore, most of the grid cells had a relative risk less than 1, remaining below epidemic levels. So in summary, accounting for WASH variables in Model 2 and then CATIs and WASH in Model 3 resulted in normal levels of relative risk, so not excess, given the presence of those interventions and activities. Next slide, please. So the strengths of our study highlight real-world uncontrolled conditions, daily data collection, a large sample size in the thousands, variation in geography across 3 Nigerian states, and a novel space-time analysis, or at least a novel application of SAT-scan, scan statistics. Our limitations include a selection bias, of course. The cases included in the study were only those seen at the cholera treatment centers, and then subsequently received a CATI response from the teams. The certain survey results were dropped if we were missing data, and we could not look at free chlorine residuals in the study as 50% of the FCR data was missing, but we're looking at that in a subsequent paper. And finally, we processed and cleaned the data remotely in the US, which made things difficult as they were being collected on the ground, and cleaning the data, mapping the data, so on and so forth. So next slide, please. So now I'll hand it off to Paul to discuss implications. Thank you.
Thank you, Michael, and thanks, everyone. So first and foremost, the results provide evidence justifying the continued use and scale of CATIs and cholera outbreak response, and in this case, particularly in fragile settings such as Nigeria. Or northern Nigeria. And CATIs were associated with reductions in cholera clustering, despite many of the operational challenges that have been mentioned, and I think Flavio mentioned many previously, and I'll go through some shortly. Additionally, the CATIs in our studies we're not OCV, oral cholera vaccine, as well as antibiotic chemoprophylaxis were not included. And while these are clearly important and have been shown in the discussions today how important they are, they certainly will not always be available. And therefore, CATs without those two interventions were able to reduce cholera transmission, which is quite important. So, and as we know, there are going to be remaining issues in terms of production and supply of OCV. And then, despite evidence that shows that the antibiotic resistance for chemoprophylaxis is low when it's targeted, there still remains in many government recommendations, standard operating procedures, the recommendation not to use antibiotic prophylaxis. So previous research has underscored that the timing of CATs are hugely important, and Flavio also mentioned that in his presentation. However, SI and ACF, particularly in Adamama, began their responses a few weeks after the outbreak was declared, and this isn't unusual in many of these settings. However, our research shows that CATs, even after a few weeks of the declared cholera outbreak, that the CATs still played an important role in reducing cholera transmission. However, we've seen with this massive amount of cases, the larger caseload, it makes it difficult to reach a high proportion of these cases, which is key for operational challenges. And I think that's one of the important aspects of this study, is that the operational component in a real world setting. Next slide, please. So partners responding to cholera outbreaks must take active measures to prepare for potential operational challenges. And therefore, this preparedness cannot be understated. And I'm just going to talk of some of the challenges. So the high caseloads, as I mentioned, make it very hard to provide CATs to a large proportion of cases due to logistical constraints. The high population density resulting in a high number of households within each CAT ring. This further relates to the radius length. So while a longer radius may be appropriate in a rural environment, in an urban setting, such as Borno, there could be hundreds of households within a 150-meter radius. Therefore, the more households in a ring, the longer it's going to take to complete each ring, and fewer CAT rings each team is able to do. There were supply stockouts throughout, both at the warehouse and at the team levels. And this greatly hindered the CAT quality, with the majority of households not receiving the complete packages. Implementing partners, the other aspect is communication between implementing partners, from NGOs to government, from health to WASH sectors, have to have strong coordination and ensure proper data partage sharing, as well as a timely CAT response. And lastly, the responders operating in fragile settings will always need to contend with insecurity, and this was a big issue during the response. Next slide, please. So there also remains research gaps that our study is trying to address, and many of them have been discussed by the colleagues. Particularly should the impact of individual factors on the CAT effectiveness. So we hope that some of the upcoming manuscripts that we're planning to look on was the phase 2, the CATs and free chlorine residual and household drinking water supplies, as well as 2 other methods papers, some of which Michael discussed briefly. Next slide, please. So in conclusion, our research found that CATs have the potential to reduce cholera transmission in fragile settings despite the numerous challenges, such as the high population density, the supply stockouts, and the security constraints. We used a novel spatial temporal methods to prospectively analyze the clustering of cholera cases in the presence of CATs. And our findings highlight that CATs were associated with a reduction in cholera clusters during the outbreak, and that the clusters of cholera cases were fewer, were smaller, and occurred for a shorter duration. And they were less likely to reoccur in the presence of CATs. Next slide, please. So importantly, the study's novel methods and comprehensive scope expand upon previous research, collectively strengthening the understanding of the value and applicability of CATs in conflict and fragile settings, and support their continued use and scale up. Last slide, please. So this was, as Patricia mentioned, a lot of people were involved. ACF, SI, Daniel Lantain, who's on the call, together with Hopkins, various groups within Hopkins. And we really want to thank everyone. Many are on this call as well, and hopefully we have some time for questions. And over to you, Pierre, Yves.
Thank you so very much, Patricia, Michael, and Paul. Very, very interesting presentation, impressive work done with ACF and Solidarity International. So thank you so very much. I have a few questions on the chat, and thanks, Jennifer, for answering to the first one. But from Jenny, thank you on informative presentation, great work. Jenny would be interested to hear about the latrines bedding disinfection from the implementer and more from communities. What were the use, success, lessons, challenges, effectiveness on this part? Over.
Patricia, why don't you?
Okay, thank you so much. Really, it was quite interesting, and we saw that from the implementation on ground, so many of the households and case households, including the neighbors, were so interested for their beddings and their household to be disinfected, because they saw what was happening around their household, and so they wanted even the partners to also go to their households to disinfect their beddings and other structures within the household. So really, they accepted our intervention wholeheartedly. And I think that was one of the reasons why we had a large number of data to be collected. I think that was what we saw in Borno and Yobe State for Action Against Hunger. Thank you.
Thierry Solomon from Solidarity International is on as well, and he may be able to respond to that as well from another perspective.
Yes, thank you very much, Paul. It's the same. I agree with Patricia. It was a huge success. We had a lot of people welcome the idea of disinfecting their latrines and their beddings, especially seeing that their neighbors, their wards have come down with cholera. But though in some locations we encounter challenges, some people do not accept, but afterwards, after a lot of consultations with the community leaders and all, they later got to find out the importance and then why we had to disinfect their environments, which included their beddings and the latrines, which could be a reservoir for the transmission. And then they allowed the CADI teams to actually go on with the implementation. Thank you.
Thank you very much. And here for me, it's an opportunity to highlight the value again of the research, operational research, because when we speak about bedding, about latrines for cholera, I can't think about Danielle and her past paper targeting this question. And actually, I have a question from Danielle on which part of the CATI is most important and what we should focus on in a limited funding situation, both across WASH and health intervention. And maybe just to clarify Danielle's thoughts, the work presented by Ruan and Michael both includes modeling and comparison of interventions, and other data from other groups shows synergistic impact. So basically, from your point of view, what do you think if you were an organization with limited funds? Is there any intervention you would pick up as a top priority? And if you don't know, what research is needed to answer that question? Over to you, Patricia, Paul, and Michael. Thank you.
Yes, I'll say for us, the hygiene promotion messages is one key activity that can be done in such situation. In Nigeria, especially for Action Against Hunger, we have been responding to cholera outbreak just with the WASH intervention. And so with our limited resources, we have really worked very closely with the state Ministry of Health and that of Ministry of Water Resources, including the local government and stakeholders and community leaders, to make sure that those hotspot locations are reached out every year and sensitized on the importance of prevention of cholera outbreaks. So for us, the WASH intervention is key because we really don't have the luxury of the vaccination. So that is one key intervention I feel can be done with limited resources. Thank you.
Thank you very much. I know we have a colleague from Solidarity Online. Do you want to you wish to add something on that point?
For me, no. It's a tricky question. I'm not sure we have the data now to be able to respond to that. But yes, I would lean towards the hygiene promotion, just as Patricia has mentioned, because once people are aware, there's a mass campaign, they know what cholera is and how to prevent, then maybe they can take steps on their own to curtail or contain the outbreak locally at the household level. But since in the absence of data, it's difficult for me to respond to that question. Thank you.
So let's keep this interesting question for future research and future discussion. It has been a real pleasure to have you today, to have this fascinating discussion. We had no chance to come back all together, but I think we had very good questions and answer after every presentation. So many thanks to all our presenters, speakers, and for all of you for the incredible questions. Over to you, Tonia, for next present webinar. Thank you very much, everyone.
Thanks, Pierre-Yves. And yeah, thanks again to everyone that presented today and for all the questions. It's great to have too many questions